I'm Elizabeth Ciemins, and I'm the Vice President of Research and Analytics with AMGA. Today, together with two of my colleagues, we are going to talk about an HPV vaccination best practices learning collaborative. And I will let my colleagues introduce themselves when they come up. Who is AMGA? We are the American Medical Group Association, a 501c6 trade association, and our members are healthcare organizations, multi-specialty medical groups, integrated delivery systems, as well as academic medical centers. We work with our members around population health, helping with that movement from volume to value. As part of that, we work on quality improvement, and we conduct a number of initiatives, one being shared learning collaboratives, and that's what we're going to focus on today. These are intimate gatherings of our members, about 10 to 20 groups get together and work on a specific issue. In this case, HPV, but there's a number of others that we've worked on. We also conduct national campaigns around a specific area. These are lighter touch, more participation, and we have one coming up this fall on adult immunizations, and we may have an opportunity to address adolescent immunizations as well. Research and Analytics is the department that I sit in. And in here, we take data from our members and pair it with shared learning. And that's exactly what we did for this HPV Best Practices Learning Collaborative. We also conduct research, usually in partnership with an academic medical center. We work in measure development. Mostly we want to sit at the table around measure development and make sure measures are meaningful on behalf of our members. And we also do implementation studies. And these studies are to implement and translate evidence into practice. We have over 400 members, 175,000 physicians. Our member organizations are of varying sizes. And really, our members are all working towards improving population health, where it's their business strategy. And that's what we do, is support them in this endeavor. So here are some of our members. And here are the 8 members who participated in the HPV Best Practices Learning Collaborative. So how did we get here? So I mentioned that we have a history in best practices learning collaboratives, and we did a number on adult immunizations. We started with a pilot, we wrote that up. Then we went on to scale up and spread 2 more cohorts of about 20 organizations each. And after this work, we were invited by the National Adult and Influenza Immunization Summit Steering Committee to present at the National HPV Vaccination Roundtable Integrated Delivery System Task Group. They knew what we had done. This task group was interested in trying to figure out how we can work with health systems on improving HPV vaccinations. So we presented what we had done in the past on with adults, and decided to partner and come together and create the Best Practices Learning Collaborative for adolescent HPV vaccinations. And this was done obviously in partnership with the HPV Vaccination Roundtable, as well as the American Cancer Society, and supported by CDC and OIDP. So the objective of our program was to develop and implement evidence-based strategies and interventions to improve adolescent HPV vaccination rates in multi-specialty medical groups and integrated health systems. And we did this using our best practices learning collaborative framework. So what does that entail? So if we start at 12 o'clock here with the advisory committee, we were lucky enough to have partnered with the National HPV Roundtable, which already had a number of experts who were happy to participate as advisors in this learning collaborative, and really helped us with everything that we did as in the collaborative. Next, about 1 o'clock, you can see measurement and QI tools. So the advisors helped us choose the most appropriate things to measure, as well as what qualitative tools we would be using. We do outreach and coaching to the groups and by AMGA and by our advisors. Typically, we have in-person meetings with networking. We had to shift quickly to virtual. We were lucky enough to have our first kickoff meeting as an in-person meeting, which gave us the opportunity to meet each other, but then had to pivot to virtual. We normally conduct our site visits in person, but we did those virtually, and they really were a smashing success. We have webinars monthly or bi-monthly in this case. We share tools, we share resources, and in the end, we sort of wrap it up with case studies, a white paper, publications as appropriate. But really what this is all about is benchmarking and shared learning. And I can't emphasize enough the importance of shared learning, and that's really bringing all these different organizations together, letting them see how they do on measures in relation to each other, but also learning how different groups made that happen, sharing strategies, sharing lessons learned, et cetera. So now I'm going to turn it over to my colleague, Earlean Chambers, who is going to talk about some of the specific quality improvement activities.
Hello, everyone. My name is Earlean Chambers. I'm the Director of Clinical and Quality within Population Health Initiatives within the AMGA Foundation. And as Elizabeth mentioned, one of the major components of the HPV Best Practice Learning Collaborative is quality improvement. We coach members in developing their HPV program in several ways. As you can see here, we have outreach calls, emails, virtual site visits. The outreach calls and the emails were very important to connect with our members throughout the collaborative. We learned a great deal from those. We kept them motivated, and we learned what are some of the challenges. Because of COVID, we had to do virtual site visits. Prior to that, we would go to the organization and meet with their entire team to learn about all the work that is being done behind the scenes. But because of COVID, we had the virtual site visits. This was our first time, and it was great. We still got a chance to meet with all of the team. We were able to learn what they did in their program. We were also able to provide learnings from other groups to help them in areas where they have some challenges. The QI documentation and reporting part of the collaborative is also very important. At the beginning of the collaborative, QI charter and project requirement documentation was needed. This was to add structure for the groups in their programs, but it required them to meet with their teams and really look at what they wanted to do and answer those questions of what, when, how, where, and why. And once they submitted that a project requirements in the charter, then throughout the collaborative, they were required to submit their action plans. Now, the action plans was a working document, and this included knowing what the goals were, knowing what your objectives are, and knowing what your interventions are, and implementing those. This was submitted bi-monthly to the AMGA team, which it really helped the AMGA team to learn about what the groups were doing throughout the collaborative and to be able to look at all the ways that they have been successful, what are some of the challenges, and as Elizabeth mentioned, to be able to share that information with other groups. The PDSA cycle and the gap analysis is one part of the QI process. In this collaborative, we did not require them to submit their document, but we also encouraged them to do a PDSA cycle and a gap analysis as a support for their QI improvement. So our collaborative interventions for the groups came in 5 different buckets. Despite COVID, the groups were able to implement interventions in these areas of education, patient outreach, gap closure, visits, and EHR resources. Education is a part of all of our collaboratives, even though we do know that education alone cannot move the needle in the collaborative. So it needs supporting interventions. As you can see here, their education came in provider and staff education. There was community meetings, provider department meetings, clinical staff meetings, and there was even peer-to-peer coaching. And this peer-to-peer coaching was between providers. They also implemented weekly newsletters. Patient education was focused really on, because of COVID, with letters, text messages, emails, MyChart messaging, and these messages out to patients was to try to get them to come in for scheduled visits if they were overdue or if they were due. Lots of education occurred at the point of care because when they had them there at the office, they took the initiative to educate them about the HPV vaccination. This not only occurred through the front desk staff, this occurred through providers and the clinical staff as well. Patient outreach was another bucket for interventions with phone calls, MyChart messaging, and letters. Phone calls was a predominant method of outreach because of the COVID. All of the groups participating in the collaborative did multiple phone calls to their patients with the focus to try to get them to come in to schedule visits and also to give them information in regards to their immunization statuses of their child. Gap closure was important as well. These are 3 reports that were developed to close the gaps for HPV. The first one, which is one more dose due, was a report that would look at what is one more dose due for that patient to complete the series. This report was used to try to call the patients to have them come in to complete their series for HPV vaccination. Now, the enhanced pursuit list occurred at the time at the point of care. This was used to, at pre-visit planning, to look at those patients that were coming in that were overdue for their vaccinations or were due. And they used this list to target those patients to ensure that they got their appropriate vaccinations when they were in the office. The missed opportunity report was another report to look at if patients did not get their vaccination when they were in the office. What was the reason behind that? How can they do better? And to also monitor that over time to see if they're making up for all those patients that have missed their vaccinations. And then we had the visits. Visits were very important due to COVID. Some groups had telehealth visits, and that was the preliminary part of the visit that they could do without having to come face-to-face with the patient. There were weekend visits where Saturdays and Sundays where they opened their clinics to make people feel comfortable and also to be flexible and allow parents to bring their kids in to get their vaccinations. We all know about the well and the sick child clinics and where you're separating clinics to ensure that there was not a crossover during COVID between the sick child and the well child. Drive-through clinics was also tried and was successful in one of the groups. And then there was the focus on well child visits. And the thought here was if we can focus on well child visits, immunizations will be part of that, and we can improve our rates just by focusing on getting those kids in for those visits. The EHR resources were health maintenance alert and best practice alerts. It wasn't that they didn't have these alerts already established in their EHR, but what they did was they brought this, it was at age 13. So they changed those best practice alerts and health maintenance alerts to be at 11 to 12. So the doctors, this is a part of the education process, is to make sure that the doctors are aware that instead of vaccinating starting at age 13, that they would start at 11 and 12. Dashboards and scorecards were also created, additional information for the provider. And last but not least, but very important, was the transparent reports, and which was done at the provider level so that providers, not only providers and staff, they could see where they are in their rates of HPV vaccination. And also they can see where they compare among all of their other peers. So right now, I am going to turn this over to my colleague, Cori Rattelman, who will talk about data. Thank you.
Great. Thanks, Earlean. My name is Cori Rattelman, and I'm the Senior Research Analyst that supported this collaborative for AMGA. I'm going to talk to you today about the performance of the organizations, and I'm going to share with you the average performance and highlight improvements for the collaborative over the 15-month intervention period. So I want to start by focusing on the patients. So across the 8 organizations, they touch more than 128,000 adolescent pediatric patients aged 9 to 17. And here is sort of the age breakdown for that. So about 52% of patients were 13 to 17-year-old, 26% 11 to 12, and 22% 9 to 10. And now I'm going to shift to talking about the measure rates, but I'm going to keep that population up there because remember, those are actual children and shots in arms. So we started by measuring HPV initiation and completion, or up to date, by age 13, and then for adolescents 13 to 17-year-old. And this was just to reflect what we see with the NIS teen survey, national data, and then also the HEDIS measures for adolescent vaccinations. And you'll see for each measure here, we have two bars. So over here, these dark green bars under HPV initiation by 13. The one on the left is going to be the vaccination rate at baseline, which was 2019 Q4, so the 12-month ending December of 2019. And then the bar to the right of that for each measure will be the latest data reported, which came from Q1 of 2021. So you'll notice, as everybody's mentioned, COVID is right in the middle there. So pretty much all of 2020 was significantly impacted by that. We got together in February of 2020 for our kickoff meeting. And when we talked there was a lot of discussion on vaccinating younger patients. So a lot of the organizations were really excited about the opportunity to kind of shift their focus towards these younger patients. So we did add a couple of measures. We added HPV initiation for patients 11 to 12 and completion of the series for 11 to 12-year-olds, and then also HPV series initiation for 9 to 10-year-olds. And so you can see the two bars for each of those measures. And you'll notice that the collaborative improved in all measures for adolescents age 11 to 17. So despite sort of the timing with COVID, they were able to achieve that. And the highest relative improvement we saw were for the by age 13 measures, both HPV initiation by 13 had a 14% relative improvement, and then a 15% relative improvement for HPV completion by age 13. And then we wanted to kind of put this into a number of patients. So we look at each of the organizations and the improvements that they made on the individual measures. And we see how many patients that would have impacted. So for 11 to 17-year-olds, we see that there would have been 5,100 additional patients that initiated the HPV series. Again, among 11 to 12 and 13 to 17-year-olds. And this is as a direct result of the improvements made during the collaborative. And then 5,000 additional 11 to 17-year-olds that completed the HPV series due to those improvements. So that's something we're really proud of, and I know the organizations are proud of. So now we're going to shift. And we're going to look at some individual organizations and kind of use their experience in the collaborative to demonstrate some concepts that we think are really essential for successful quality improvement. And the first is that you can't improve what you don't measure. So this first organization had never looked at HPV vaccination rates, which was common among several of the collaborative members. So they kind of expected their rates to be low. They know they have some regional challenges. They took a look and estimated the measures. So here I'm showing HPV initiation and completion for 11 to 12-year-olds and HPV initiation and completion for 13 to 17-year-olds. And these are their baseline measures. They saw the data. They were a little surprised how low it was. But then we got together in February and we benchmarked their data against all of the other 7 collaborative members. So everybody had their rates fully identified. And they were really shocked with not only the fact that they were the lowest among the 8 groups, but really there was a significant difference between where they were at and then the next highest group. They also had the lowest rates relative to state and national benchmarks, so looking at the NIS data. So they took this data home in February and the benchmarking report and shared it with their providers and staff, and nobody was happy. So they really wanted to get going and get started on kind of pushing those rates up right away. In April, just a few weeks later, the COVID national emergency was declared. So even though they had done a lot of great planning and continued to plan throughout the collaborative for a lot of their IT improvements, things to support transparent reporting, best practices alerts, some electronic outreach to patients, a lot of that stuff was stuck in the queue during the pandemic, as it was for a lot of groups. So really, they were able to kind of meet with their providers, do provider education, some patient education, and really just get everybody focused on HPV. So a lot of the improvement came from the fact that people just didn't like being where they were at relative to the other groups, and they were really motivated to make a change. So in the end, this organization improved rates for all adolescents 10 to 17 years old. And that ranged from 3% to 16% absolute improvement across the different measures. So you can kind of see them highlighted here. One exciting area is that they tripled the rates of completion for age 11 to 12-year-olds. So that's for the HPV series completion. You can see they went from 7 to 23%, and that reflects 1,000 more 11 to 12-year-old patients just at this one organization that completed the HPV series as a direct result of the improvements that they made. They also closed that gap with the state NIS teen rates by about 65%. So you can see here the two light blue lines represent that state rate for HPV initiation and then completion, and you can see them marching towards that. So I'm hoping they'll close it here soon. And then as a bonus, they improved the rates for established vaccines. So we also measured vaccination rates for meningococcal vaccines and Tdap. So these were sort of used as an internal benchmark for the groups so that they knew kind of what can you expect to reach in terms of vaccination rates within your organization for adolescents. So they improved meningococcal vaccination rates from 44% to 59%, and their Tdap vaccination rates from 75% to 85%. And again, this was really by measuring was the biggest thing that they were able to do and really jump-started their efforts. So in order to improve something, you have to measure it. Super helpful if you can benchmark it against other organizations or at least some national data or quality measures, and then share that internally. You'll really see that it can motivate folks. So this leads me to my next example, that providers are motivated by competition. So sometimes that competition is internally. So this organization is a provider-owned healthcare organization. On the flip side, they started out at a very high rate. So they started with the highest HPV initiation for 11 to 12 by 13 and 13 to 17-year-olds across the collaborative. They also were above their state and national benchmarks for HPV and also meningococcal. We're showing the HPV state rates here with the light blue lines. You can see how they're doing. And they did this by really using a robust transparent reporting. And their transparent reporting was focused coming into the collaborative on the percent of patients that had their well visits. And by having their well visits, they think that patients are more likely to meet their prevention measures. So they're more likely to get their vaccinations. And in fact, that's what we see. And even though they started out at a super high rate, they continued to make steady incremental improvements throughout the pandemic. And that was by really focusing on HPV, doing provider and patient education, and outreach. So again, a lot of their IT improvements got stuck in the queue during COVID, and they were really able to do this because they have that transparent reporting, focusing on well visits, and now they're talking about HPV. They also met their individual goals for HPV initiation 11 to 12 and by 13. That means that they reduced their unvaccinated patient population at baseline by 20%. So you can see those highlighted there in yellow. And really, this is just an example of why transparent reporting is, when done right, can really be successful. So in order to be successful, transparent reporting needs to be transparent down to the provider level and the staff level. Those reports need to be pushed out. Don't rely on the providers to pull that data. Use that data to set goals to achieve an ultimate outcome. If you want to meet an 80% HPV vaccination rate, don't set it at 40 or 50 for the providers. Tie that to value-based compensation if possible. And then the most important thing is provider and staff must trust the data. So work with them, show them their data, and make sure that they trust that that reflects what they're doing on the ground. Now I'm going to hand it over to Elizabeth, who will walk you through one more example.
Thanks, Cori. In this last example, I'm going to talk about leveraging a culture of rapid change and transformation. So at this organization, you can see that they started with the second lowest rates in the collaborative to start. But they ended up improving in every measure. As you can see, they shot past their individual goals for the HPV series initiation and completion by age 13. That's what's highlighted there in yellow. They improved up 24% and 19%, which is huge improvements on those two measures. And then, despite COVID, they were the only participant to improve in the 9 to 10 age category. So that's there on the far left, it's highlighted. They improved, they were up 8% from 13% to 21%, which was an amazing improvement for a really hard age group to move. So how did they do this? Well, this organization had a culture of rapid change and transformation. They were an agile organization. We've worked with them over the years. One thing that they did in this case was setting expectations for parents and patients early. So the very first time that a parent came in with their infant, they were given a book or a booklet that laid out everything that was going to happen in their tenure in pediatrics. So all the vaccinations that were coming in all the time frames. So they knew what to expect and they knew what was expected of them from the very start. They also, as in the previous example, did transparent reporting, and it was expected. It was part of the culture at this organization. So physicians and providers expected to see what their rates were so that they could compare with their peers, with themselves, and across practices and across the organization. They also gained leadership buy-in and support, which is really important. And we encourage all organizations to start at the top and really get leadership to agree and support the programs. And that really switches when you get to the clinical practice team to a concept of ownership. So fostering ownership for an initiative is really important. And that means inviting everybody to participate, inviting everybody's input from the beginning. So it's not buy-in, but it's really owning a project. And this includes everybody throughout the practice team so that when parents or patients come in, they're receiving the same message, a unified message across the practice. And they were really able to maintain this agility for rapid transformation. Another example from this group is in a previous collaborative on adult immunizations, they used standing orders. And instead of just implementing it as a way for nurses to give shots, they really thought about it as a way to empower the workforce. So, and this gets back to that idea of ownership, where the nurses now felt empowered and they really owned the process by being given that ability to give shots themselves without having to check with the provider. And they also were open to feedback from everyone in this collaborative and others, and they left time for reflection and sense making along the way. And all these things really contributed to this culture that really allowed them to be successful, not only in this initiative, but in other initiatives. So to summarize, we know benchmarking is key. Facilitated shared learning is where the magic happens. You can't say that enough. It's really bringing organizations together to learn from each other and share, and also see how they're doing through the benchmarking process. You can't improve what you don't measure. It might be something as simple as just looking at your data, and that can have an impact. Providers might be motivated by competition. It might be with themselves. It might be with their peers. It might be across practices. It might be across, the whole organization. And that's where the transparent reporting comes in. And finally, culture change is slow, so start now. There's a lot of little things that you can do that will impact not only this and your current initiative, but future quality improvement initiatives and programs across your organization. So here's our team. We want to thank you for this opportunity to be part of this collaborative, for the partnership, and for this opportunity to present our findings. Feel free to reach out to us with any questions, and thank you for your time. Have a nice day.